consequences of TBI, the brain injury may affect how they move, how they think, how they act, how they feel, how they communicate, and how they relate to others. It can affect how people think, how they feel, how they behave, how they speak, how they understand language, and oftentimes also how they move and their sensory motor functions. Like I said before, the example of the woman I just spoke with, you know, her son had to learn how to walk again. So we've got some examples. So when we talk about cognitive, what we're talking about is impaired attention, memory, language skills, and complex cognition. This can include judgment, insight, and problem solving. So again, you have to think about the filter that you all have. Imagine if what you think, you automatically said, every single thing, right? That's probably not, there's probably some things that I think that I probably shouldn't be saying out loud. I mean, nothing really outlandish, but you know, I may be driving in a car and somebody may cut me off and I may go, oh, what a jerk. And then I'll have to go, well, maybe he's in a hurry. I don't know. He's probably got something going on in his life. So I'm not going to judge that person. But sometimes people with brain injury, they don't have that filter. So you might be sitting here thinking, wow, she talks fast, but you're not going to automatically say that to me. And I have to think to myself, yes, I have to probably not talk so fast. So the example is that when you're working with your clients with brain injury, that filter that say, maybe what I'm thinking I shouldn't be saying is sometimes completely gone. And these folks can have a myriad of mental health concerns, from depression, anxiety, to rage and aggression, to being impulsive, to focusing on one thing like the weather and not moving on to the fact that they're about to lose their apartment because they can't pay rent, those types of things. They may be paranoid. There may be some sexual inhibition. Someone may say, I find you really attractive, you know, and I would like to do XYZ with you. And you have to say, well, you know, thank you for the nice compliment. It's not really appropriate in this situation. I'm trying to help you find a job. Maybe don't say those things on a job. So working on those types of things, being paranoid, and also hoarding. So a lot of times people with TBI hoard because they don't want to forget anything. So they don't want to throw anything away because it helps them remember.
And then we do have a question from the chat. What determines whether someone has a post-concussive syndrome or TBI?
Okay, that's a great question too. So when we get to severity, we will talk about that. And that's a great question. And I'll just go ahead and briefly answer it right now. So as we saw earlier, mild TBI is around 80%. Most people that have some type of concussion, their symptoms completely resolve within a few months, usually 2 months. People, there's about 15%, depending on what study you look at, if it's military versus civilian. There's a small percentage of people that have something called complicated TBI and may have these post-concussive types of syndromes. And these are the folks that have the ongoing symptoms that don't go away. And that could be, you know, the memory, the headaches, the problems with sleep, those types of things. So it usually is, one way they determine that is through imaging, if it's positive or negative. Concussion doesn't always show up on imaging. It's a little bit beyond my scope because I don't do imaging type of work. I'm not that type of a PhD, I'm not an MD. However, usually there is a way to do a checklist for post-concussive syndromes following TBI, and then seeing the length of time that they experience those. So having, you know, rechecks with a neuropsychologist is typically how they can diagnose that someone has this post-concussive syndrome. And post-concussive syndrome is TBI. So a concussion is a brain injury, and a brain injury can include someone having a concussion. Not everyone gets these post-concussive syndromes or the PCS. However, those that have the ongoing symptoms beyond that initial typical recovery time is the person that will be diagnosed with those post-concussive syndromes. And it can include PTSD, it can include, like I said, depression, headaches, memory issues. There is a mild traumatic brain injury task force within the American Congress of Rehabilitation Medicine. And they just came out with a new, they're working on a new definition of mild TBI and post-concussive syndrome. So what I can do is I can make sure that I share that with you, and that'll give you a little bit more detail about that. That's a great question. So in terms of how brain injury might affect speech and language, there could be issues with understanding language or speaking language. They may have trouble communicating. I see a lot of times people are like, I know the word, I can't find it. Can't find the word. So it's really important to be patient with people with brain injury, not try and complete their sentences, and give them time, have that uncomfortable silence so they can do their best to find those words. They may repeat the same phrases over and over again, or may have some broken speech, or may not complete their thoughts. Some of the physical and sensory motor type of issues can include, like I was saying before, some of the seizures, headaches, dizziness, balance and coordination. They might have some weakness on one side of the body. They may have some hearing impairments or visual impairments, depending on the location of the brain injury. May have some trouble swallowing, impaired taste and smell. I'll see what I notice. It's been a little bit more challenging with COVID, but before, what I would always look for is, did the patient report that they were, lost a sense of taste or smell? And that's something that's very common in people with brain injuries. And in some hospitals, they'll have them smell those fruit markers. I don't know if you remember those. They're kind of thick markers. There's like the grape, the orange, the yellow. I remember them from when I was younger, but they would actually use something like that to test their sense of smell within the acute setting. Chronic pain, sensitivity to light. So I was working with an individual, wonderful, wonderful woman. She was working at the Pentagon during the 9/11 attacks. And when I met her, she was wearing a ball cap and sunglasses. And she says, I have to wear this all the time. I cannot, the light is so much for me. It overstimulates me. It makes me, nauseous and dizzy. She was working in a office in the Pentagon, and she'd walked away to get something, and her coworker had come into her office. Well, her office was hit. Her coworker didn't make it. She did. And so she grappled with that and went through counseling to kind of process that. But ever since then, she's like, I can't go to movies. I can't go anywhere where there's loud light or noise. So sometimes when I am evaluating someone with a brain injury, and they'll be wearing sunglasses, and if it's on Zoom per se, I'll ask them if they want to turn off the light. And they're like, but you won't be able to see me. I'm like, I probably can see you. And I turn off, they say, oh, it'd be great if I could just take a break from the light. And they take a break from the light. They're like, oh, it's like a weight has been lifted off me. You have no idea. Like, I can't be in the light. So thinking about, the photosensitivity of these individuals and other sensory impairments. Something else is sensitivity to heat. So I worked with, we used to run brain injury camps, and there was this one individual that I knew I had to watch him because Florida's hot. It gets really hot here. And so if we were doing anything outside, I'd have to ask whoever was working with that group, monitor so-and-so, because if he gets too hot, he has seizures. And so we would have to, periodically say, you need to go inside and take a break. Oh, I don't need to take a break. You do. And then he'd have a seizure and be like, I told you, you need to go inside and take a break. So thinking about that too, that can also affect people. In terms of returning to work, just based on what we've said, of course, those things are going to, cause challenges with people attempting to return to work. Unemployment is high among these individuals. Not that many return to work. They can, but it's more challenging. It's harder. There's a lot of neurobehavioral issues to consider, as well as stamina, those types of things. So depending on the research and the sample that they use, we've seen, between 30 and 70%. So talking about here, we have some post-concussive symptoms here. Neurobehavioral symptom inventory is one that is used often. Sometimes it's called the NSI. And this can look at different domains with symptoms. So the affective domain would include low frustration tolerance, irritability, anxiety, tension, difficulties getting organized, like things don't get finished, they may forget, and they may not be able to make decisions, or may not be able to get started on something. That's a big problem too. We talked about some of the vision problems and the sensitivity to light and noise. That would be somatosensory as well as vestibular. And this is, people can be off balance, feel dizzy, or have poor coordination and clumsy. Going back to the camps I used to teach, it was the day of checkout. There were a bunch of duffel bags on the floor, and somebody had not pushed their duffel bag underneath the registration check-in area. And one of the women there who had a brain injury was very limited on one side of her body with her hand and her leg. So she kind of dragged her foot when she walked. She got her foot stuck in one of those duffel bags, tripped and fell, cut her eye, had to get stitches. But someone maybe that didn't have those types of limitations, the balance and the poor coordination, may not have had that severe of an injury if they had also tripped on a bag. So COVID-19, we have to talk about it, but it really affected people. It affected people that serve people with disabilities. It affected the people receiving services and the families that were supporting those people in those settings. So in an ideal world, people with brain injury will get comprehensive rehab for a good period of time after the injury. Unfortunately, many insurances have a limit on the number of days of rehab someone can receive. And I'm going to tell you, it's never enough, right? Because TBI is a chronic condition, so these things are ongoing. This is a lifelong condition. So in the ideal world, there would be, inpatient rehab, then outpatient rehab that would help them address complex independent living activities, how they would return and reintegrate into community, group homes or skilled nursing facilities if they need them, outpatient residential settings, or supports in the home for these people. But unfortunately, it's not enough what's currently being offered for most people. So in terms of outpatient and day treatment facilities, during COVID-19, these were suspended. So of course that impacted individuals' recovery, as well as telehealth playing a major role, reducing contact among people. And it's not completely back to where it should be. We're getting there, but there is still a challenge, and they still have to adapt rehab services and approaches as we continue to mitigate things throughout our world. So there's a couple citations here. Jim Malik is well known for his work in Indiana, as well as my colleague, both these are my colleagues, Dr. Terry Pagoda, she's at VA Boston, and she had an article that talked about supportive employment for veterans with traumatic brain injury and remote counseling and implications of that. So in terms of TBI and COVID-19 tip sheets, some examples would be with a person, use the 20-minute on, 20-minute off approach, rule to technology, meaning they probably need to take a break after 20 minutes to help reduce their cognitive fatigue. I sometimes get Zoom fatigue. There are some days I'm on Zoom. Well, it's not as bad now, but I used to be on Zoom like 8 or 10 hours a day, like maybe with a couple of brief breaks. And I would just get so exhausted. I couldn't look at people on the Zoom, and come to find out there actually is a thing called Zoom fatigue, because if you're actually in a setting in a room with people, you're looking around, you're talking to people, you're moving, you're adjusting, you're shifting. But when you're on a Zoom, you're staring at this camera the whole time. Now, probably I'm not seeing you all, but probably some of you are, maybe not looking at the screen the whole time, and that's fine. You can certainly still listen to me, but it can be problematic and especially more challenging for people with brain injury. Virtual meetings can be a challenge, and it's sometimes hard to understand what's going on. Oh, and there may be technical issues, like someone trying to turn on their video or someone trying to get the sound for a video. So it can be frustrating, but we learn to live with it. But there are some fact sheets to kind of help guide you as we continue to navigate, our hybrid environment that we live in. So people with TBI sometimes have less access to care, and the ones that do don't have really great outcomes. I mean, it makes sense. You don't have access to treatment, you're probably not going to do as well from treatment because you're not going to have access to it or get as much of it, right? So what we have seen is that people who are uninsured don't do so well. They're more likely to pass away after TBI. Ethnic minority groups are less likely to receive the follow-up care that they need. And there might be related poor psychosocial, functional, and employment related outcomes for these folks. So we need to think about that. And this is really important. I see a couple of chats here, and I do want to answer them, but let me get through this section and I'll come and I'll take a look. And I do really appreciate that you guys are engaged and actually typing questions and things, because sometimes I never know if someone else is what they're doing while I'm doing these types of trainings. Okay, again, more on less access to TBI care. It's not surprising, but if you live in a rural area, there's probably going to be less available to you compared to people living in, say, an urban area like of Atlanta, where the Shepherd Center is, which is, one of the premier TBI rehab centers in the country. Some of the problems with folks living in rural areas and them having a higher risk of dying from brain injury is that, it takes time to get somewhere to the emergency center. They may not have access to a level 1 trauma center. They may have difficulty in getting services such as specialized TBI care. So the 2 individuals that we saw on the video, one was medevaced, and the other one had a chopper come pick him up, and he was flown directly, I think it was to Denver, and then he followed up at Craig, which is a wonderful TBI rehab facility. But they had helicopters. If somebody is in a TBI in a rural area and someone doesn't find them for a day, they're probably not going to do as well, right? Also, folks that are homeless, they are more likely to experience TBI fights. I remember in Gainesville, people would be like, let's go beat up bums. I didn't say that, but like I would hear people say that, and I'd be like, what are you guys talking about? No one should be hurting anybody. But like, the homeless population is targeted, unfortunately, and that can result in more brain injury. And brain injury that's undiagnosed and not treated. So in terms of organizations that are available for these folks, there's the Brain Injury Association of America. There's NASHA, or the National Association of State Head Injury Administrators. You've got the United States Brain Injury Alliance, the Military Health Systems TBI Center of Excellence, or the COE. One of the ones that I personally like to use in my classes is the Model Systems Knowledge Translation Center, which is the MSKTC, and they have fact sheets and videos and other materials for people living with TBI, their families and their caregivers. So they have fact sheets, they have videos, they have ways to become a TBI ambassador. So again, that's the Model Systems Knowledge Translation Center. And they have also things available in alternate languages. Model Systems also has the same type of resources for spinal cord injury, as well as burn patients and burn injury. So sometimes you might have somebody that has a TBI that also has a burn because they were in a car accident and the car caught on fire, or they were in an IED and they have polytrauma. So they have, burns on their skin and they have a spinal cord injury. And then they also might have a brain injury associated with that accident as well. I'm gonna look here now. So Myrta spoke on the chat and she said, having difficulty getting accommodations and services through the school system after her son had been in an incident at school which caused brain concussion and spine damage. Yeah. Some of the side effects you mentioned she complained about, but the school has not recognized as substantial effect her life or education. Any recommendation? Well, yes, IDEA and a 504 plan, and your brain injury association. I don't know where you live, Myrta, but there are advocates for that and people that help you transition to school after brain injury. In Florida, we have a brain and spinal cord injury program, so I'm not sure where Myrta is, but what I would recommend doing is you could go to the, click here, the Find a Brain Association in your state, and then that can help you navigate. So normally there are transition counselors for transition aged youth. There's also literature by Dr. Rumrow, you know him, he has some literature on adolescence and school transition as well. And then we've got Bridget here wrote, I have a consumer recently released from a rehab center. He lives alone and isn't aware of available services. I don't know if the rehab center made referrals for him. He just hasn't followed through or remembered their information. And that's critical because people might be given information and either they lost it or in the moment they were worried about just surviving or something else. And then maybe they never followed through. So handing somebody a piece of paper saying, call this person isn't enough. So there's an approach to targeted case management for people with traumatic brain injury. It's called resource facilitation for brain injury and following brain injury. And that's where someone called a resource facilitation coordinator does an intake with them, talks to them about what they need, gives them information about resources and in the area, either does a warm handoff or does a phone call to the organization, or they follow up, within a few days. Hey, it's me, I'm calling again. Have you followed up with so-and-so? So you're absolutely right. He may not have followed up, but he may not have anybody that's reminding him to follow up. Okay. And so again, finding the Brain Injury Association in your state is great. Sometimes there are targeted voc rehab counselors targeted TBI voc rehab counselors in states. That is hit or miss. There was a HRSA survey that looked at all the different services that were provided across the states, and they can vary far and wide in terms of what's available in certain states, but going to maybe the national center can help you, I think, get those things. Yes, Medicaid is a huge problem because folks that have Medicaid, so the case I was talking about earlier, he has Medicaid, he's on SSI. The places that take Medicaid aren't always the premier places for rehab, and so that's a challenge. And so it depends on the state and where you are. Like in Florida, they have a Brooks Rehab where they have a community transition type of employment clubhouse, but it's funded primarily through a private source. So there's nothing like that that's really funded for Medicaid. Yeah, after discharge is tough. And transportation is tough too, because oftentimes they can't drive. And the paratransit, at least here in Florida, isn't great because it takes, like, you know, they could be late, they could not show up, you have to schedule them ahead of time. So it's not always, transportation is a huge problem for employment and for treatment. So something that's getting a lot more buzz lately is trauma-informed care. So when we talk about trauma-informed care, we talk about an approach to delivery of behavioral services that includes an understanding of trauma and awareness of the impact it can have across settings, services, and populations. So the way it views trauma is through an ecological and a cultural lens, right? And it recognizes that this has a big impact on how individuals perceive and process their traumatic events. So going back to the woman I told you about at the Pentagon, she took approach of, instead of saying, why me? I have it on one of our videos. She says, well, why not me? I was chosen to go through this. I was chosen to be an advocate. I was chosen to be a leader. So the approach of the half full, half empty, it has a huge impact on someone's recovery and how they perceive themselves and how they transition to their new identity following this type of injury. So again, there's a link here to SAMHSA's trauma-informed care services related to behavioral health. When we talk about trauma-informed care, this is a strengths-based service approach. It's grounded in an understanding of and responsive to the impact of trauma. It emphasizes physical, psychological, and emotional safety for both providers and survivors. And it creates opportunities for survivors to rebuild a sense of control and empowerment in their lives. So ethical and cultural and ethical considerations. Of course, you want to consider minority populations and how that might impact the rehab and recovery process, as well as military and veteran populations. And in reality, we're all multicultural. Every human's multicultural. We're not 100% one thing. I've never seen an Ancestry DNA report that has someone being 100% anything. I could be wrong, but I haven't seen one. So most people are multicultural, and even if their DNA is, doesn't show different backgrounds, our world and how we view our world and how we experience our world makes us, multicultural. Cultural humility is something that we all need to strive to consider when we work with folks. So when we think about identity, cultural identity is comprised of many factors, including where we live, the socio-political history, and our personal lived experiences. And you better bet that politics shapes how we see the world, because these are people that make the rules and provide the funding and, agree to renew or to not refund different types of services. And again, there's a lot of characteristics that make us our own selves, right? So this could be our ancestry, this could be our ethnicity, our age, our gender identity, our sexual preferences, our disability status, level of education, profession, what language we speak, and any other sort of factors that can affect that, including, demographic factors. So when we think about multicultural ethics and behavioral health, we want to think about diversity and multiculturalism. And in the end, what we want to see is that in a diverse world, that people acknowledges the difference that exists among individuals. In a multicultural world, people accept and embrace the difference of others. And so, you know, just realizing that we're all different and trying to accept each other, it's a very basic kind of thought, but we really need to be mindful of how we see the world and how we see the world might affect how we interact with other people. And we're all going to bring a different lens, and it is what it is. And that's okay, but we need to at least acknowledge that. Okay. Yes, you should get a copy of the email, the PowerPoint. So trying to understand different people's world's views. I do not know what it is like to live in a country in South America that is under conflict and consistent political unrest. I have not lived in a family where I've gone hungry. I've been very blessed in my life. It doesn't mean that I am better than anybody else, but that has just been my experience. Now, through my ability to do mission work, my ability to do exchange programs in other countries, having a husband that comes from a different cultural background than mine has kind of broadened my lens and my understanding and my appreciation for that. And also my work in social services, right, with the Medicaid population. You know, I realize how fortunate I've been to be educated and to have a secure place to live growing up. When I did some work in South Africa, I remember speaking to one of the folks at the counter, and she told me, if you come back here in 6 months, half these people aren't going to be here. They're going to be dead. They're going to be dead because they have HIV, or because they're killed, or because they have a cell phone and someone shoots them and kills them for their cell phone, because you will get shot and killed for a cell phone here. I was told this. I don't worry about being shot and killed for my cell phone. And it's, I feel very fortunate. However, we do have to realize that not everyone lives in the world that we live in, and we have to appreciate that and how that will affect them, not only in their access to care and their recovery, but how we might interact with them and provide them services and counsel them. So in terms of our locus of control, we've got, our internal control, the beliefs that beliefs that reinforcement are contingent on their own actions and that they can shape their own fate. And then you've got the external control, right? Reinforcing events occur independently of their own actions and that the future is determined more by chance or luck. So when we think about the locus of responsibility, this is the dimension that measures the degree of responsibility or blame placed on the individual or the system itself. So you want to think, again, just about your worldviews. You want to think about someone's work background, their economic class, their age, their race, their income or economic status, their religious beliefs, or some people don't have any spiritual religious beliefs. That's fine. That's up to them, whatever works for them. Their gender identity, sexual identity, and then disabilities. So when thinking about who you are as a person, how do your dimensions of diversity influence your experience, your values and beliefs, and your attitudes and behaviors? Because undoubtedly, you have some things that were taught to you and that you learned over time throughout your life. So what can happen with us when we work with folks is there could be some issues with culture and perspectives. So if you are counseling someone that might look a little bit different than you or come from a different background, depending on the culture, there may be some mistrust there. People may automatically assume some certain types of stereotypes about people. It may affect their ability to seek behaviors. I was interviewing an individual in Miami, and he was from probably one of the roughest parts of Miami, from my understanding. And he told me, I don't talk to people about this. I can tell I can trust you, doc. However, I can't be seen as weak in my community. That will be my demise. I will die out here. I cannot be seen as weak. People cannot know that I'm going to go talk to somebody because I don't feel right. That just doesn't fly in my community. And so what we were able to do was find him a text chatting service to kind of help him with some of his needs. But, I don't live in a place where that is my experience, but I need to honor his experience. And that's what he's bringing to this type of relationship that we're forming. And so understanding that someone may not be trying to seek help, not because they're being defiant or because they don't want to get better, but there may be some other factors in play, or their family's going to see him as weak, or the family doesn't, the family doesn't believe in counseling. You go to the church, you go to, the shaman, those types of people to help you with your problems. So you have to think about this when we're working with folks. And then microaggressions, unfortunately, they exist. A lot of times they're not even intentional, but they do exist, but they can really affect your therapeutic bond and the rapport building with your clients. So across sex and gender, you just got to think about what you know, what you believe and how you feel. And what you know and what you believe and how you feel is fine for you. But that really should not be coming into the counseling relationship. Trying to have, a very objective type of approach will be great when you're working with your when you're working with your clients. You need to understand that even if maybe you're not part of a population where you've come out, that there could be some issues related to that. I've had such diverse experience with students and with clients that I have to realize that I have to constantly be getting, continuing education and training, because I don't understand some of these populations that I'm not quite as familiar with. So I was working with an individual who had recently come out to his parents, and he was having, a hard time, right? His mom was okay, his dad wasn't. We had to talk about how we could kind of work around that, some things that he could do to empower himself. We got him to some community centers that kind of could help him with that more locally in his area. And so just being aware of that no one has to be an expert in everything and fully understand everything, because that's never going to happen. And realize that we do the best that we can. We try to seek continuing education. We try and be understanding. It doesn't mean we don't have to adopt the views of every single person in this world, but we have to understand our views, and we have to understand that, number one, our clients come first when we're giving them services. So whatever you need to leave, you leave in that closet, and you come very objective with your client, and you look at how can I help them mitigate their symptoms, reintegrate in the community, get a job, feel supported, and accept them. So I'm more of a Rogerian type of approach when it comes to counseling, but really thinking about that is important. And interestingly enough, the client who I helped find a position recently, who came out to his parents and who relocated, he wanted to go work at an LGBTQ community center. And he was working with me for career counseling, and he asked me about, they gave him how would you work with this client? You have a client that's coming in that's gender nonconforming, transitioning, homeless, lost their job, HIV positive, all of these things, right? So I can't remember the full scenario. And he said, well, if they're using drugs and they're HIV positive, I probably need to get them to, a clinic where they can get clean needles and things like that. And I said, well, it doesn't say anywhere in here he's using IV drugs, and you don't even know if he's still using. And so these are the types of things that sometimes we just automatically assume things, but they may not be the case. So I guess what I'm trying to say is, don't assume. It's better to ask. And then that way you can work from there once you really understand where the person is. Identify social, political, economic, and cultural factors that affect others. Well, the state of Florida, there's a lot of politics going on in Florida, and I'm not going to go there in this call. However, those things are impacting how we educate and how we teach. And it could be, challenging for folks, and it certainly could cause some challenges with accreditation and those types of things. When you work with the military, if you've never worked with the military before, it's really important that you get some sort of background on their culture and become somewhat competent. I am not a service member. However, my stepfather was in the Army, my grandfather was in the Korean War, and I've had the benefit of working with a lot of folks with brain injury that I've served over the years. I have been able to work in the VA, and I do not say, you know, I'm not a veteran, I'm not an active duty member. However, you know, I do have some family and I certainly appreciate your experience. There are things in that culture that I had to learn about hierarchy, following rules, expectations, timelines, those types of things we need to be very concrete in terms of duty. And that can sometimes be a challenge when transitioning to civilian culture. So there is something called a military to civilian checklist that I use sometimes with my clients. And also understanding that the realities and the training and the structure, being so structured within the military is something that they're used to, and maybe perhaps in more civilian jobs, those things aren't as clearly defined. And so understanding that. So this is an example. There's a link here to a course. It's called Military Culture, Core Competencies for Health Professionals, PTSD, National Center for PTSD. So understanding military culture can allow clinicians to tailor their practices. Okay, this can also be true for helping people get jobs in the community that may be transitioning. So there's a course here that you all can do, and it's free. There's also a telemental health training for military counseling training. This actually does have a cost associated with it. I'm giving you a few different examples here. This module offers clinicians comprehensive knowledge and skill-based material on military culture, medical, psychosocial, behavioral, mental health, family life, career transition, and resiliency needs of their clients. Another course is called Psych Armor, and this is the courses for military culture. And this is online training videos that are delivered, and they're at no cost. Before I started co-chairing the Behavioral Health Networking Group with the American Congress of Rehab Medicine, I was the chair of the Military and Veterans Networking Group for a few years, and we provided some courses on military culture and training. So under an unemployment following brain injury, as you know, and through our discussions today, can have serious effects for the individual themselves, their support systems, and their communities. Failure to return to work can result in poor psychosocial outcome, including decreased community integration, and really can increase economic dependence. So there was a systematic review. Oh no, this wasn't the systematic review. This article by Shames et al. 2007 shows about returning to work following TBI and the populations that they were working with. So we're going to talk about severity. So someone with a mild TBI may or may not lose consciousness and may be disoriented. Those with more moderate types of injuries usually are out for longer periods of time. And those with severe injuries can be out from, you know, a day to weeks or months, depending on. And I will pull up, I thought I had put the severity index in here, but I guess it didn't. I'm not seeing it. And how you define the difference between mild, moderate, and severe TBI. So the populations served here are anywhere from mixed severity of TBI, which means we include mild, moderate, and severe, to those with severe with stroke, with CVA. So there are different studies out there that look at different return to work rates. So it's really important to know and kind of think about, is it a mild TBI? Is it a mild TBI with post-concussive syndromes or more of a complicated TBI? Is it a moderate TBI or is it a severe TBI? And truthfully, those with more severe injuries usually have more problems getting back to work, along with, you know, those that are older might have more challenges. So there are some predictors of return to employment following brain injury. And there have been a lot of factors that have been shown to influence that rate, not always 100%, but most of the time. So someone who's younger, who's more educated, who has better access to rehab and care, someone that has a pre-vocational history where they had learned a skill or a trade, someone someone has good social supports. Those people tend to do a little bit better because they have more wraparound available to them to support them.